Welcome to another talk in the series Surgery for Undergraduates. Today's topic is a very interesting and important topic, liver abscess. Okay, the types of liver abscess. There are three main types. Most common is the pyogenic liver abscess, or the PLA, which is the most common abscess, which accounts for about 80% of hepatic abscesses in the US. And here, I'm sure it is also as high as that, you see. 3/4 of the abscesses are due to pyogenic. Second is amoebic liver abscess due to ant amoeba histolytica, which accounts for about 10% of cases. Right? Amoebic abscess used to be a very common cause of liver abscess in the recent past, but today it has been more or less reduced to a very small number of cases. Fungal abscesses are very rare. We'll go through some facts about pyogenic liver abscess. Pyogenic liver abscess, or PLA, is a type of liver abscess caused by bacteria, which can be single or multiple. The right lobe is affected twice as often as the left, and 5% of the time there is bilateral involvement of both lobes of the liver. No cause is found in 15% of cases. Most are secondary to infection originating in the abdomen. Bacterial endocarditis and dental infections are other common causes. It is more common in the immunocompromised patients and in people with liver cirrhosis. The origins and cause of pyogenic liver abscess. The main source of the pyogenic abscess organisms is from the biliary tract, like gallstone disease, acute cholecystitis, empyema of the gallbladder, cholangiocarcinoma with secondary infection, and bile duct strictures or stones leading to cholangitis and formation of severe infection ascending into the liver and causing abscesses. Okay, the biliary tract source has become today the most common source of liver abscess. Next is portal vein. The spread of the infection through the portal vein from infections in the abdomen, such as appendicitis, diverticulitis, Crohn's disease, and other infection sources of peritonitis in the abdomen. Direct extension from the gallbladder, perforated peptic ulcer, and subphrenic abscesses are another important source of pyogenic liver abscess by direct extension. Trauma is another important cause, especially penetrating trauma to the liver, and sometimes even blunt trauma to the liver causing massive injury, followed by secondary infection and abscess formation. Of late, iatrogenic causes are becoming another common cause of liver abscess, especially with the invasive liver biopsies, various forms of liver biopsies, liver aspirations, and so on, blocked biliary stents, ERCPs. All these are produced or predisposed to infection spread to the liver and cause liver abscess. What are the organisms that cause this liver abscess? First, anaerobic bacteria, which account for 60% of the pyogenic abscesses. And the most common is the Bacteroides species of organisms. Secondly, the gram-negative bacteria from the gut, enteric gram-negative bacteria, of which the E. coli or the Escherichia coli accounts for 40% of the cases. Klebsiella pneumonia, 10 to 20%, and others 4 to 40%. Gram-positive bacteria are less common causes of liver abscess, and the most common among them being the Staphylococcus aureus, which accounts for 4 to 25% of the liver abscesses. Now come to clinical features. What are the clinical features? Acute abscesses are usually multiple, and these abscesses can come in within a matter of days to a week. It can also be chronic and single at times. Abdominal pain, malaise and lethargy are the very common symptoms of liver abscess. Generally, the patient feels sick and unable to function normally. Low-grade or high-grade pyrexia, okay, and this fever is usually accompanied with chills and rigors. The liver is enlarged and tender, okay, the liver is enlarged and tender, and this enlargement is more towards the upper end of the liver to push the diaphragm on the right side upwards, which result in the pulmonary symptoms at times: cough, chest pain due to the pleurisy, and breathlessness. Differential diagnosis for liver abscess are listed here, among which the first four are the most common: acute gastritis, bacterial pneumonia, liver disease such as biliary infections, liver cirrhosis, and polycystitis, with acute polycystitis with empyema of the gallbladder. These are all differential diagnoses that must be considered in a patient presenting with features of liver abscess. The investigation is recommended for patients with pyogenic liver abscess. First, a full blood count with the total white count, which is often raised in these patients. Sometimes can be raised as high, moderately raised, okay, not mildly but moderately raised. Stool examination for amoebic cysts or the amoeba itself, culture and sensitivity for bacteria, especially in cases of typhoid, where you can culture the typhoid bacillus. Abdominal ultrasound and ultrasound guidance aspiration to establish the diagnosis of a liver abscess. And if cases are still in doubt, a CT scan will be of very great use. CT scan guided aspiration also can be done to detect liver abscess. Okay, fine needle aspiration cytology attempted may draw frank pus, and that will confirm the diagnosis of presence of abscess. The pus is sent for gram stain, culture, and sensitivity, so that the right antibiotics can be initiated. Okay, this is a plain X-ray of the abdomen of a chest of a patient with pyogenic liver abscess. So you see here, the right lobe, right hemidiaphragm is markedly elevated compared to the left. Okay, elevated right diaphragm due to the abscess in the right lobe of the liver. This is an ultrasound images of liver abscess. This is a pyogenic abscess. In this case, there are two abscesses in the liver, and this is an amoebic liver abscess, which is usually solitary and large. A difference between hepatoma and liver abscess on CT scan. Okay, on the left, this is an hepatoma. It shows an enhanced lesion, which is irregular margin and is radio-opaque due to increased uptake of the dye, contrast that is given. Okay, whereas in this patient, this is a pyogenic abscess, solitary pyogenic abscess. You see, it is well encapsulated. The edges are smooth, and there is a peripheral halo around this abscess. Okay, white due to edema. So this is a classical changes seen in a pyogenic abscess. is different, markedly different from the changes shown by an hepatoma or hepatobiliary carcinoma. Now, what are the principles of treatment of pyogenic abscess? Okay, the first principle, you must drain the pus. Like abscess anywhere, the pus has to be drained. Then you must give a proper antibiotics, strong, broad spectrum, and appropriate. Okay, those are the features of the antibiotics. And then you have to deal with the underlying source of infection. If it comes from cholecystitis, then the gallbladder has to be removed. In summary, the percutaneous drainage combined with antibiotics has become the first line and mainstay of treatment for most pyogenic liver abscesses today. Okay, treatment consists of three parts. First, initially the treatment is always conservative. Multiple small abscesses may respond to antibiotics, which should be given intravenously and then changed to oral for 4 to 6 weeks. Okay, these antibiotics must be in high doses and given intravenously to be more effective. Second, if these antibiotics cannot cause the resolution of these abscesses, then a percutaneous drainage is attempted. This is usually done using a needle aspiration under ultrasound or CT guided aspiration, and the drainage is sometimes using an indwelling pigtail catheter. Irrigation of the abscess can also be done with saline to dilute the pus and enhance its or facilitate its drainage through the pigtail catheter. If this does not solve the problem or adequately, then surgery is attempted. And this surgery is either open method or through the laparotomy method or a laparoscopic method, which is becoming more popular these days. So in summary, the surgical treatment consists of aspiration, transcutaneous and pigtail catheter insertion to continue the drainage of pus. Failure of this, you go for laparoscopic drainage. Or if it is not feasible to do a laparoscopic for some reason, then you go for an open drainage through laparotomy. Okay, a summary of the treatment options: antibiotics, aspiration, percutaneous drainage using an indwelling catheter like a pigtail catheter, and surgical drainage, either laparotomy or laparoscopy. Now I have to emphasize again, percutaneous drainage plus IV antibiotics is the treatment of choice for all pyogenic liver abscesses. Okay, this diagram shows you a direct aspiration using a syringe. The needle is under ultrasound guidance or CT scan guidance, is introduced into the abscess cavity and the pus drained. If you are unable to drain the pus or the pus is very thick, then sometimes you may want to introduce a catheter with a coil tip known as a pigtail catheter, so that the coil tip can lie within the cavity of the abscess, thereby reducing the risk of slipping out. Okay, this is the diagrammatic view. The syringe, using the syringe, the needle is inserted into the abscess cavity under ultrasound guidance or CT scan guidance, and then the pus is aspirated. Very often this does not solve the problem, as the pus is usually very thick and unable to drain all the pus. So in many cases you may want to put an indwelling catheter or pigtail catheter, okay, but the tip is coiled and placed in the lumen of the abscess, in the lumen of the abscess, whereby increasing the drainage of the pus. Okay, this is a pigtail catheter. This is the coil tip which is introduced through a guide wire, and then this is placed inside the cavity of the abscess in the liver. Thereby, the pus is drained out through this tube. And it can also be flushed through this tube using saline. Regular flushing to dilute and increase or improve the flow or drainage of the pus through the drainage tube. Next, I'll briefly touch on amoebic liver abscess. This used to be a very important or the main cause of liver abscess in our patients in the recent past. But today, amoebic dysentery and amoebic liver abscesses have become, the incidence has become very, very low even in our country. Okay, the cause and pathogenesis of liver abscess. Liver abscess is caused by the amoeba known as the Entamoeba histolytica. It is always a complication of amoebic dysentery, which is a precursor to the formation of liver abscess. Okay, infection of the colon leading to amoebic dysentery. This can occur in an acute stage, that it takes place within a matter of days to a week, or it can become in a chronic carrier stage. The amoebic cyst is ingested and develops into a trophozoite in the colon, and then this trophozoite passes through the bowel wall and to the liver via the portal system. After reaching the liver, the organism causes destruction of the liver cells or hepatocytes by releasing powerful cytolytic enzymes, resulting in liquefaction and necrosis, leading to abscess formation. The clinical features: the initial stage of amoebic hepatitis, where the amoeba causes massive destruction to the liver cells. The severe pain in the right hypochondrium due to enlarged liver microabscesses, which can be usually seen in ultrasound scans. During this phase, the patient has got, apart from pain, he has got low-grade fever, weakness, and anorexia. At times, the fever becomes high-grade with chills and rigors, which is a result of secondary bacterial infection converting the amoebic abscess into a pyogenic liver abscess. At times, thoracic symptoms are also very prominent because of its vicinity to the diaphragm and the diaphragmatic pleura. Non-productive cough is a very common symptom and then pain due to pleurisy and right shoulder region are very common. Other signs include anemia, jaundice, if the abscesses are multiple and cause compression of the biliary ductules, liver enlargement in the right hypochondrium. Again, this liver tend to be tender, and the enlargement is in the direction of the diaphragm, okay, upwards. Investigations are similar to pyogenic liver abscess. Total white blood cell count is very important. There's an increase in the total white cell count. Stool examination becomes very, very important in these patients with amoebic abscess, where you may be able to detect the ova and cysts of the amoeba. If it is a chronic carrier, then serological testing may be more important. The indirect heme agglutination test, detecting the antigen of the amoeba. Chest X-ray, as I've explained, will show an elevated diaphragm and some lung changes if there are. So it becomes also a very important investigation. Ultrasound scan is another important and vital examination that must be done for all patients suspected of liver abscess. It will show multiple or solitary abscess cavities. If this is not able to give us enough to diagnose the patient, a CT scan of the abdomen should be done, especially involving a hepatobiliary gland. And I've already explained the changes that are classically seen in a case of liver abscess on CT scan. Treatment is basically conservative in almost all the amoebic hepatitis patients. When abscess develops, then we may resort to other forms of treatment as well. So the initial treatment is metronidazole or flagyl, 400 to 800 milligrams 3 times a day, even for 14 days. Okay, this is a very high dose. It's double the usual dose for colonic amoebiasis. Ultrasound guided needle aspiration and insertion of pigtail catheter for continuous drainage are introduced. In most cases, becomes necessary in pyogenic liver abscess, as the abscesses tend to be large and unable to resolve with antibiotics and aspiration alone. Occasionally, if aspiration and drainage fail to drain the abscess adequately, surgery may have to be considered, which can be either laparotomy, that is open surgery, or laparoscopy, which is becoming more common these days. Thank you for being with me during this lecture. I hope this short lecture would help to improve your understanding of pyogenic and amoebic liver abscess.